Hello, I'm Elise Hartleben, an assistant professor and physician lead for physician scheduling for the Department of Emergency Medicine at the Medical College of Wisconsin, and I am an assistant medical director for one of our clinical sites. In this lecture, we will discuss utilization and the impact of external staffing agencies. The Wall Street Journal reported in 2023 that approximately 50,000 doctors, or 7% of the U.S. physician workforce, not including foreign medical student graduate, currently practices medicine via temporary assignments or locums. And a 2022 survey of locums tenens staffing trends by A&M Healthcare found that 88% of approximately 200 hospitals, medical groups, and other healthcare facilities surveyed reported using locum staffing in the past 12 months, with 14% reporting use of emergency medicine locums use. When we reflect on why locums are utilized, we first have to recognize the growing need for healthcare in this country. In a 2021 paper in the Annals of Emergency Medicine, Marco et al. Projected visits in 2030 to grow between 7.8 and 13.4% from 2017. This is driven largely by the increase in the U.S. population, especially the population over age 75. Another important factor is geography, and specifically the lack of rural physicians. Cross-sectional analysis of the 2020 AMA Physician Master File database of approximately 50,000 clinically active EM physicians and 40,000 EM trained or board certified physicians shows that there were 12.1 emergency medicine trained or EM board certified physicians for every 100,000 person in the country, which overall has increased since 2008. However, nearly all 92% of emergency physicians were in urban areas. On the other hand, they found decreases in both large rural and small rural areas, with a decrease of 3.7 physicians per 100,000 population in small rural areas. And lastly, we must acknowledge physician burnout. Encouragingly, the 2023 AMA analysis on burnout showed a decrease in overall physician-reported burnout to 48% from 53% previously in 2022. However, EM still remains a specialty with the highest levels of burnout across healthcare. Looking at all these factors, it is easy to see where there could be a gap in physician coverage that could be filled with locums physicians. In this brief presentation, we will cover locums physician utilization and its implications. Importantly, I first want to note that the data regarding this topic is incredibly sparse, and even more so for emergency medicine. And much of the data presented today is from industry studies or those performed by locums companies. Take note for those who are interested that this is a rich field for further study. So why do companies hire locums physicians? Mirroring the data presented initially, we can see that most hire locums to fill open physician positions created by expansion and increased patient demand. Other reasons for locums hiring include addressing provider burnout, testing, marketing new services, and maintaining flexibility in staffing. When looking at EM-specific data, locums are used across the country, with a higher percentage used in the Midwest and Southeast regions. Typically, shifts are longer in the 12 to 24-hour range, with locums working on average 4 to 12 shifts per month. There are a variety of large locum staffing companies across the country, some listed here. Locums physicians also have the option to create an independent LLC. In general, companies try to avoid locums physician use. Reported concerns include cost, noted as the number one concern in both studies here, as well as concerns regarding lack of familiarity of the department and its policies or pathways, and concerns regarding quality of care, among others. When we look specifically at cost, there is a large range of salaries reported for EM locums physicians, ranging from $125 to $300 per hour. Importantly, for the hiring company, that cost can be significantly higher due to initial costs such as travel and insurance fees. Additionally, use of locums physicians places increased administrative burden on a group, which increases in complexity when multiple locum companies are utilized at one time. Most importantly, concerns are cited regarding quality of care with locums physicians, as they are often perceived to present greater risks of causing harm to patients than permanent doctors. But does the data actually support this? As noted earlier, data on this topic is limited. The 2019 study here from the UK is the first review on the topic. They reviewed 8 empirical and 34 non empirical papers, mostly from the UK, with only 4 from the US and none looking at emergency medicine. And note in the study that empirical literature was limited and weak methodologically, noting almost all are relatively small studies using surveys or interviews. The most substantial study quoted is from Blumenthal et al. In JAMA 2017, in which they investigated 30-day mortality, cost of care, length of stay, and 30-day readmissions in the U.S. for a random sample of almost 2 million Medicare patients treated by internal medicine locums, provided 60 days or more care versus permanent internal medicine staff physicians between the years 2009 and 2014. They found there were no significant differences in 30-day mortality rates between patients treated by locums compared to permanent doctors. However, cost of care and length of stay were higher when patients were treated by locums. In combining all the studies in this review, they cited some limited empirical evidence to suggest that locums may have a detrimental impact on quality and safety, in large part due to locum doctors being less likely to be familiar with patients and less aware of local policies and processes, which had a number of consequences, including delays in discharging patients and safety procedures being less likely to be carried out. However, since then, conflicting literature has been published. There have been few additional studies, one looking at neurosurgical care in the United States that found no difference in short-term complication rates, length of stay, or cost, and a 2020 prospective cohort study from Ohio of hospitalist physicians that showed no statistically significant difference in mortality or readmissions between locums versus staff physicians. And importantly, to my knowledge, there is no published data on locums use in emergency physicians. So we must take into account the possibility that results may differ based on specialty of care. In summary, in many areas, there is a need for locums use based on a variety of factors. Locums are expensive and come with implications such as increased administrative burden and concerns regarding lack of familiarity. However, many of these can be addressed to help balance the overall cost benefit. In addressing need for locums, cost of locums, and administrative burden, the number one solution is to improve staff physician recruitment and retention, especially in rural and critical access hospitals, of which I will leave further discussion to another lecture. When looking at locum-specific cost reduction strategies, consider hiring local physicians who come with less travel costs, setting clear rules regarding travel and other unseen costs, and creating minimum shift requirements to help maximize travel fees and other costs, such as credentialing fees, etc. Creating clear administrative and logistical policies and procedures is imperative to avoid exponentially increased administrative burden. Some recommendations include centralizing communication, requiring completion of all credentialing and privileging before scheduling someone clinically, and transparency in staffing and scheduling needs. When addressing clinical concerns, the same ideas and values apply to locums as one would approach any other staff physician. An initial orientation of site and system policies, pathways, and procedures is a must, and ideally they should be stored in an easy accessible location, acknowledging the possibility of limited site contact per month for a locums physician. I also advocate for an on-site in-person orientation with a medical director and a full shadow shift so that the physician has time to ask questions as they come up. Lastly, creating a recurring review process for locums will help to mitigate any concerns that arise. I recommend tracking similar metrics to staff physicians, such as likelihood to recommend, door to disposition, QI events, etc. Overall, the use of locums physicians is here and likely will grow. As we reflect on the balance of coverage gaps, the burnout crisis in our specialty, and cost, We ultimately aim to provide the highest quality patient care in a timely manner. For some, locums physician use may be a part of that equation. Hopefully, in this short lecture, you gained an introduction to the pros and cons of locums utilizations and implications and feel more informed to make a balanced decision. Below are the sources I used for additional information, and I also want to highlight that many EM societies have locum sections for those that are interested. Thank you again for listening and have a great day.